Mr. Collins. And Mr. Speaker, I rise today in support of our nation's community pharmacies, which play a critical role in our health care system. Many of these independent businesses operate in underserved or rural areas, like many of the counties in Georgia's 8th Congressional District, which I represent, where access to care is already an issue and would be worse if community pharmacies did not exist. In areas where a doctor can be many miles away, local pharmacists deliver flu shots, give advice on over-the-counter drugs, and help with those late-night drugstore runs for a sick child. Many people in our rural communities see their pharmacists much more often than their doctors. There's a very personal relationship between pharmacist, patient, and the physician. As pillars in their community, they're also the businesses that contribute greatly to local economies. It's crucial that these pharmacies have an equitable playing field against large-scale competitors and middlemen pharmacy benefit managers when trying to run a successful business in a challenging and complex environment. And I want to reiterate, Mr. Speaker, all they ask for is an equitable playing field. No advantages, just equality. Where I'm from, local pharmacists are often a fixture in their communities. These pharmacists have known most of their customers all of their lives. They instill a level of trust that is unparalleled. And I frequently stop in at local community pharmacies when I'm back home in the district. I never fail to appreciate the unique value they add to their customers' lives. Unfortunately, on some of these visits, I'm also troubled to learn how community pharmacies are finding it extremely difficult to serve the people who have depended on them for years and to compete with some of the larger entities in the healthcare marketplace. Take, for example, the increased prevalence of preferred networks in Medicare Part D plans. Currently, many Medicare beneficiaries are told by pharmacy benefit managers, or PBMs, which pharmacy to use based on exclusionary arrangements between those PBMs and, for the most part, big box pharmacies. What most people don't know is that, in fact, in several instances, these big box pharmacies actually own the PBMs that are creating these preferred networks. Patients must pay higher copays if the pharmacy they want to use is excluded by the PBM, who, again, as I said, in many cases, is actually own the larger pharmacy that they force you to do the business with. The majority of the time, the hometown pharmacy is never given the opportunity to participate in the network in the first place. Another issue I often hear about from community pharmacies is the burdens of DIR fees. Most Americans probably assume that it's a pretty simple transaction. When they purchase medication from their local pharmacy, they go in, they pay a copay, and that's the end of it. But for the pharmacy, the transaction is anything but clear and simple. Pharmacy benefit managers use so-called DIR fees to claw back money from pharmacies on individual claims long after the claim is thought to have been resolved. That means that a pharmacy often doesn't know the final reimbursement amount they will receive for a claim for weeks or even months. Anyone who runs a pharmacy, or any other small business for that matter, knows you can't operate when you don't know what your reimbursements are. When competition is stifled and these small businesses suffer, so do hardworking Americans when they have had their choice to use a community pharmacy instead of a big box business taken away from them. Another issue I frequently hear about is the lack of transparency in generic drug reimbursements to pharmacies. Though generic prescription drugs account for approximately 80% of drugs dispensed, the reimbursement system for these medications is largely unregulated and a complete mystery to all of us. Now, if it's unregulated with transparency, that's fine, but it's unregulated without any transparency. And pharmacists are often reimbursed for generics via what is referred to as the maximum allowable cost list created by the pharmacy benefit managers. But the methodology to create these lists are not disclosed, nor are the lists updated on a regular basis, which frequently results in pharmacists being reimbursed below the actual acquisition cost for various medications. In recent years, these extra costs that affect prescription drug prices in community pharmacies have fallen on consumers. Take doxycycline, for example. Doxycycline is a drug that is used to treat a number of bacterial infections. As a generic antibiotic that's been around for decades, I want to repeat, it is a generic that has been around for decades. In 2012, 30 capsules of doxycycline cost approximately $15. In 2017, the same dosage cost $115. That's a price increase of 667%. I want to give you a real-world example of the impact this has on low-income patients in the world. I have a wonderful OB/GYN in my area, and he told me that prior to the price increase, he would simply keep Doxycycline in his office, and when he had a patient that needed it, he could simply give the patient, if it was a low-income patient, the drugs instead of having them go to the pharmacy to pick them up. But with a 667% price increase, they could no longer afford to simply give the patients the medication that they need. Nitroglycerin tablets is another example. Nitroglycerin tablets have been used to treat chest pain and stop a heart attack, have seen similar price hikes in the past few years. Again, a generic, it's been around for decades, no excuse in the price increases other than flat-out greed. A drug that's even more common that's been affected by the lack of transparency in the drug market is insulin. As you may know, millions of Americans with diabetes rely on insulin. They have to have it, or they will simply die. According to the American Diabetic Association, the price of insulin in America has nearly tripled over the past 15 years, making the drug nearly unaffordable for many diabetic patients. The dramatic price hikes of insulin is ironic, since in the early 1920s, Frederick Banning, one of the scientists who helped to first develop insulin, sold the patent for the drug for $3 because their goal was to make the drug affordable and easy to access for everybody in the world. Now, nearly 100 years later, one vial of Humalog can cost over $400 in the United States, while it costs a fraction of that in other countries around the world. In Canada and Mexico, the same dosage of Humalog costs less than half, or sometimes even a quarter, of what it costs in the United States. I understand that there's a tremendous cost in developing life-saving treatments and new drugs, and the next development that's going to save a cancer patient. But these are generic drugs that have been around for decades. These dramatic price increases, the international price disparities, they're occurring, again, on drugs that have been around for decades because of this pricing scam put in place by the pharmacy benefit managers. In the coming months, I look forward to continuing to work with my colleagues to address the lack of transparency in the pharmaceutical industry, giving community pharmacies an equitable playing field to compete, which gives hardworking Americans the choice of affordable prescription drugs and which pharmacy they choose to purchase those drugs from. Mr. Speaker, I'd like to thank you for your time. I'd yield back the remainder and any unused time to Mr. Collins, and I want to thank him for hosting this special order today.
Well,